I'm going to transition and introduce our panel around telehealth. So again, the same tips around, using the questions box for questions still applies, and we will try to get those at the end of the presentation. So for this section, leveraging telehealth to advance integration, we have 3 panelists who are going to be speaking around telehealth. So as you all realize, over the last 8 months, there has been a dramatic increase in the utilization of telehealth by all providers across Washington state. And while this has been a dramatic shift in delivering care for many, it also has a huge opportunity to really support integration and coordination across providers. So as part of this presentation, I will be introducing everyone before they talk. And so we have, kicking off this overview, we're going to have Dr. Christopher Chen. So Dr. Chen is the medical director for Medicaid at the Washington State Healthcare Authority, and he is a hospitalist by training. So he has been leading efforts around telehealth for Medicaid and the Healthcare Authority, and will be providing the Healthcare Authority's perspective around telehealth. Chris.
Great. Thanks so much, Stephanie. And I just wanted to check, is my audio okay?
Yeah, it is.
Okay, great. Excellent. Never know these days. Well, thanks so much for having me, and thanks for the introduction. Again, my name is Christopher Chen, and I'm a medical director for Medicaid at the Healthcare Authority, and happy to chat with you guys today a little bit about how we are thinking about telehealth. Next slide, please. I think this much is obvious. Our delivery system has undergone a pretty incredible transformation in response to the pandemic and kind of the protocols necessitated by social distancing, and I think we've transformed in the last 6 months what probably would have taken many years in terms of bringing healthcare to kind of the modern age in delivery. I think in many ways, when I talk to my Medicaid medical director colleagues from other states, it's clear that we in Washington State were kind of ahead of the game in terms of telehealth policy. And we had a broadly flexible telemedicine policy applicable to many different types of services, many different types of providers across physical and behavioral health, and including therapies. And for Medicaid, we also paid parity for telemedicine services since 2018, and had prior ongoing regular engagement with our key partners, including the managed care organizations, the Washington State Telehealth Collaborative, our sister agencies, and involvement in various telehealth initiatives and partnerships. And so that was all even pre-pandemic. And I think on the next slide, as the public health emergency was declared, we took quick and responsive action to broaden our Medicaid policies even further. So recognizing that at a time when PPE supplies were inadequate and social distancing protocols were being developed, that providers need every avenue available to them to maintain continuity of care with their patients. And so we broadened acceptable modalities to include audio-only services, as well as non-HIPAA compliant audio-visual services, and increased reimbursement accordingly. Also, we additionally opened services for interactions via texting, email, and patient portal visits. We kind of recognized that there was need for more direct support of patients and providers, and so aim to provide that support in a number of different ways, including procuring 2,000 HIPAA compliant Zoom licenses for providers who are in small practices and who are unable to obtain telehealth platforms of their own. We also distributed a number of cell phones to Medicaid clients, including tribal and homeless individuals, and laptops as well. We partnered with the University of Washington Behavioral Health Institute, which many of you are familiar with, to support providers needing technical assistance. And the Healthcare Authority also performed webinars to educate and share our telehealth policies. and had ongoing collaboration with our partners. On the next slide, we've seen some really dramatic increases in utilization, as many of you have experienced and seen yourself. And this is just a quick snapshot. In January and February, we were seeing fewer than 10,000 claims per month coming in for telehealth. And at the height of the pandemic, this increased over 30 times to more than 300,000. And we've seen uptake and increase in both physical health and behavioral health. And so as providers have kind of adapted to the new protocols and elective procedures have returned, some of these telehealth visits have trended downward, but it's still clear that we're never going to go back to the way things were before in healthcare. So on the next slide, 4 key themes that I just wanted to highlight that we're thinking about. And so I think, and these are buckets of work that we are going to continue kind of partnering with others on as well. And we recognize that for equity, that telehealth has both the potential to improve disparities by breaking past traditional barriers and social determinants of health, such as transportation, missed work and school, child care, and subspecialty access. Those are all barriers that telehealth can help with. But I think we've also been through many different advances in healthcare technology over the past few decades in terms of advances in surgical interventions and diagnostics and drugs and therapies. And through all those different technological advances, disparities still exist. And so there is the potential that telehealth can also perpetuate disparities and systemic inequities. And we know that many in our community have limited access to devices or connectivity issues, that patients' living conditions can sometimes compromise confidential discussion. Special effort must be made to make telehealth accessible to those with disabilities or who have discomfort with virtual technology. And there are also just situations where in-person care is more appropriate. And we want patients to continue to have a right to in-person care as well, should they need it. And I think that kind of leads a little bit to the next, if you just actually, yeah, stay on the slide on quality. We believe that care provided to patients via telehealth modality should have the same, if not better, standard of care as in-person care. There's been evidence, for example, that during the pandemic, decreased visits to the emergency department has led to increased mortality from strokes and heart attacks. And so it's clear that telehealth is inadequate for all services in healthcare. So it's really important for us to understand where telehealth works best. And just as kind of we've all adapted to a different world, I think we've all kind of, many of us who are working remotely are learning how to use different platforms of technology and engage in a work environment digitally. That providers also need education and training in how to conduct visits in telehealth with special attention to privacy, professionalism, and consent. And specifically for audio-only services, as a physician, I've had many meaningful conversations with patients over the phone, from discussing treatment options to counseling individuals on prognosis and discussing different goals of care. And so kind of personally also recognize how helpful audio only can be, especially where broadband access is unavailable or patients lack access to this technology. And many specialties, including behavioral health, are particularly amenable to audio only services. However, just kind of recognizing that it's difficult to predict when a physical or a visual assessment may change management. And so just being really thoughtful about where in-person interaction or audio-visual interaction plays a role is going to be important. I think there is some evidence that patients who engage over video have a better understanding of their health conditions and an ability to provide feedback than those who engage over audio only, especially with those who don't speak English as a primary language. And so I think it's important to kind of think about the right role. And kind of lastly on administrative burden, I think, we at the Healthcare Authority, given that we kind of across multiple different segments of the payer mix recognize the administrative burden that can come with telehealth, and just, you know, Medicare does things differently than Medicaid, and which may do things differently than commercial payers. And we recognize that Medicaid is just one of many payers. And while our program was more flexible and advanced in many ways than others at the outset, since other policies have emerged, we hope to be looking at ways to reduce administrative burden and align billing methodologies to the extent that we can. And so next slide, just moving forward, we are hoping to work through these various issues. There are lots of uncertainties just in the world in general right now, but kind of thinking about how the pandemic will play out, you know, how long will the public health emergency be extended? I think there is a lot of uncertainty, but the Healthcare Authority is committed to continuing to address issues in a way that supports our community and providers in a time of need. And we're regularly engaging with providers and stakeholders, in addition to navigating our various regulatory considerations. And so, yeah, thanks for having me. I think telehealth really presents some incredible opportunities to break through the many barriers. But we also know that, you know, given the complexity of our healthcare system, there really aren't panaceas here, but that with a collaboration and a focus on health and well-being together, we can really fulfill telehealth's potential. So thanks for having me.
Great, thanks, Chris, for providing that information in terms of how the Healthcare Authority is approaching telehealth. You know, there are some uncertainties, but there's definitely some opportunities going forward in terms of incorporating that into more consistent practice in terms of care delivery and integration. So next we're going to present two providers that have been leveraging telehealth in terms of integration, both before and during COVID. So first up, I'm going to present Wayne Pollard. So Wayne is the Director of Behavioral Health Integration at Columbia County Health System, and he will be sharing about how they have been partnering with the University of Washington Department of Psychiatry to integrate psychiatric services within their health system. So Wayne.
Hey, thanks, Stephanie.
Great.
Thanks for inviting me. Next slide. So I wanted to tell you a little bit about the area in which I'm coming to you from today. As you can see, we are in the southeast region of the state of Washington. And our catchment area includes towns such as Dayton, Waitsburg, and Starbuck, and some surrounding areas, with a total catchment of approximately 5,600 residents. Our demographics, it's kind of an older community. The median age is 50, but certainly seeing quite a few of folks, probably 60s, 70s, and 80s here in our clinics. And we are the third least populated county in Washington, with just under 5 people per square mile. So if you're looking for somewhere to move, come see us and visit out here. Next slide. So a little bit more about our area here. So our health ranking here in Columbia County, out of 39 counties, we are 37th for longevity, 22nd for those aggregate health factors such as tobacco use, diet, exercise, healthcare access, and quality of care, 14th for social and economic health, but we score high there at the end for second for physical environment. That's just because of the open land with lots of hunting and fishing and camping and hiking and such. So our folks can participate in those activities, at least right in their backyards. As far as mental and behavioral health goes, the state average is 3.8% as far as the folks who describe mental and behavioral health care as poor. Here, we're not doing as well. You can see there 4.2% scores as doing poorly here in this area. 29% of Medicare patients so far, and I think that's trended upwards since I've done this slide a little while ago, have been diagnosed with some sort of depression, and 14% dealing with anxiety here in our clinics. Next slide, please. So what's on our campus? We right now we have a critical access hospital called Dayton General Hospital. We are level 5 trauma centers along with being a level 3 cardiac and stroke center. We've since added also, since I've done the slide, wound care with the bariatric chambers there. We also have a skilled nursing facility attached to our acute care facility on the campus here. And then we also have 2 primary care clinics, the one that I work at here in Dayton on the main campus. And we have a satellite clinic about 15 minutes away in Waitsburg, which is in Walla Walla County. Next slide, please. So back in 2017, we started exploring approaches and options to behavioral health integration. We knew we wanted to build a program, and we wanted to give some time and some thought to what might work best here in our community. So we, after doing some research and development, we finally reached out to the University of Washington to adopt their AIMS model of care. And what was important for us was rapid access to assessment and short-term management of acute issues. Longitudinal care, very important, and you know, as we move along in our program, we see how important that has been so far, and will likely continue to be. And with the emergence of population-based care and value-based care in healthcare, that was something very important to us as well. We looked into the UW model too, because it was important for us to have an evidence-based practice for behavioral health. And then we had to consider the context of inpatient and outpatient care. Would we focus on one or the other? And as you'll see in the next few slides, we chose to do both. Next slide, please. So let's talk a little bit about inpatient consultations with our UW psychiatrist. And I'll use interchangeable UW psychiatrist or our psychiatric consultant who we contract with. For the acute care facility, we have access Monday through Friday, 9 to 5 p.m. And by contract, we have an hour a day of hospital to consultant curbside service, in addition to a direct patient to psychiatric consultant telemedicine visit. An hour per day is available as well for our patients there. Next slide, please. Some details about our inpatient telemedicine program. You can see there by the slide, I won't go into it too deeply, but the registered nurse is part of the team and gets the patient, gets the telemedicine cart actually set up in the patient room, remains in the room for the encounter to help with tech issues and also for communication issues between the two, the consultant and the patient, and to be part of that treatment planning at the end of the appointment. Our psychiatric consultant from UW, they are all credentialed with us, so they have access to our EHRs and document as such. They conduct assessments, they discuss diagnostic impressions, treatment recommendations with the patient before the consult ends, and then not long after, also discusses the diagnostic and treatment recommendations with the hospitalist in addition to dropping the note in our EHR. Next slide, please. So here is a slide that kind of outlines and gives you a visual of our collaborative care model here at the outpatient clinics. You can see in the middle portion, the patient is certainly in the middle of our care model with our PCP at the top, the behavioral health consultant or care manager, as well as the psychiatric consultant. You can see the relationships there with the dotted and the solid lines. And we also keep a registry to track the population and to track the outcomes so that we have less chance that patients fall between the cracks. It is a team-based care model, and the behavioral health consultants we employ treatments such as problem solving, behavioral activation, motivational interviewing, also EMDR. We're both providers of EMDR as well as cognitive behavioral therapy. And also, we do these systematic case reviews with our psychiatric consultant. Each behavioral health consultant has an hour per week with the UW psychiatrist to present usually 5 to 7 patient cases, sharing, of course, the EHR, discussing kind of what's going on currently, maybe some past history, maybe some changes in behavior or mood. And so the consultant can then take all of that into consideration and And if he decides to then make treatment recommendations and medication changes and recommendations, which then drops to the EHR for the PCP to consider and consult with the patient, and then decide if there are going to be some changes. And then as a behavioral consultant, we continue to meet with the patient. Next slide, please. So our outcomes on the inpatient side. Over time, the encounters from the patient to the MD has been growing over the time. And also the reasons for consults in the very beginning of our telemedicine program, it was really heavy-handed on the SUD focused diagnostics and treatments, and certainly those are still going on. But over time, what we've seen is an increasing general psychiatric and co-occurring disorder phenomenon of most of our patients on the inpatient side. Next slide, please. And the outcomes for our primary care. So as I discussed, we've had for a while those appointments between each consultant and the psychiatrist. But in addition to that, we also have 2 one-hour appointments on schedule each week that we connect our patients with the UW consultant psychiatrist directly. This does not happen with all of our patients. It's typically folks who are struggling much more often and more deeply than the general population, and which we see here in our practice, and also some of the more difficult diagnostics and treatment recommendations, and sometimes when the patient just requests it. This is usually a one-timer. We let our patients know it's not like a quarterly psych review that folks can often expect from a psychiatrist. We do have 2 behavioral health consultants here, considering hiring a 3rd. This was at the time that I made the slide, of course, the patient caseload changes, but typically anywhere between, I would say, 65 and 130 or 140 shared patients at any given time. And you can see there the percentage that typically return for follow-up care. 90% in-clinic visits, that of course was not happening at the beginning of COVID, but certainly as time has gone on, maybe because we're rural, most of our folks actually here do have access, most of them, not all, but most do have access to telehealth tablets and phones and Wi-Fi. But honestly, and it was a little shocking to us, most of our patients have, after a couple of months, have decided to re-engage in mostly face-to-face. We do offer also phone sessions for the few people who just really don't prefer a video session. As you can see here, we've had some symptom response, 40 to 50% of the active panel being able to improve those PHQ and GAD scores. And several calls per week, you can see there at the end, the PCP to psychiatric consult. They also are very open to curbside consults, kind of right there on the lam, and are able to get some questions answered for the folks, for the patients who they're treating. Next slide. And I think that might be it. Thank you so much.
Thank you, Wayne. I think you guys really were able to bring in psychiatric services to your county and your clinic. That I know that there's a lot of areas in Washington that don't have access to psychiatrists, and I'm glad to hear your success in doing that, both in inpatient and outpatient. So thank you.
Hey, thanks, Stephanie. Thanks for the time.
Yeah. Again, please put, if you have any questions, you can put those in questions and we can get to those at the end of the presentation. But next I'm going to introduce Ethan Seracka. So Ethan is the Director of Whole Health Innovation for Sound and a marriage and family therapist by background. And he will be sharing about Sound's experience with incorporating telehealth into their service delivery. Ethan?
Thank you. Next slide, please. So a little bit about Sound. Sound was originally founded in 1966 as the Seattle Mental Health Institute, and it came from the decision to deinstitutionalize the psychiatric facilities in Washington. And since then, we've grown and joined with other organizations throughout King County. We now have 17 locations. And our care philosophy is based on an evidence-based model called Reaching Recovery. Thank you. Next slide, please. And as that goes, keys to care at Sound are about addressing the whole person. So making sure that we're taking into account the biopsychosocial medical view. It's about active engagement in the care. So making sure that our clients are actively participating in the services that they're receiving. And part of that also means that we are sharing goals and treatment plans across the system so that all the providers working with the client have the opportunity to engage and support and ensure that our client is receiving the best care possible. But it also allows us the ability to hopefully pinpoint and target interventions earlier so that clients have less time of being impaired. Personalized care is the other big piece of Reaching Recovery, and it's providing the right treatment at the right time, at the right intensity. And I think that with telehealth, we've actually been able to personalize our care even more, because it also means that our clients have now really been able to kind of determine the right way to receive the care that they need or the care that they want. And so telehealth has been a huge piece for us in meeting that personalized care. And then coordinated care, making sure that our providers are working together to support clients. And so that's whether that's our behavioral health and substance use providers, our primary care providers, our medication assisted providers. We want them all working together internally and working from a shared care plan, but more importantly, we want them working together externally and connecting with those providers in the community. Again, kind of this has improved since we've been able to do telehealth. We found that there's additional ways to be able to take part in some of the activities that happen outside of Sound. Next slide, please. So Sound has attempted to adopt telehealth several times over the past few years. And we ran into some difficulties in the early days. Initially, we were constrained by physical locations as Sound interpreted the Washington administrative codes and some of the early payer definitions of what will be allowed for telehealth. We weren't able to go from a Sound location to the community, even if it was client choice, or at least we didn't interpret the rules that way. That has changed over time, but in the early days, we didn't quite work as conveniently. And so we were constrained by physical location. And so we actually invested heavily in a hardware-based system that would allow our providers to have a telepresence at any location at Sound. And this was a very useful tool, I think, for helping to backfill, helping to cover, helping to provide services at a location that they didn't have a service provider at, or a service provider maybe out. This was particularly important for our psychiatric providers, as it allowed them to be able to provide a location without having to travel throughout the county, which also meant that we had more time available to serve clients. However, what it didn't necessarily provide was a good choice for clients that couldn't make it to a Sound location. The early attempts were also, there was a lot of concern internally about how do we do telehealth? What are the things that we have to have in place? How does privacy work? How does safety work? And so I think it impaired our adoption because there was just so much unknown. And then in the last few years, we've actually begun to really look at how do we expand telehealth? How do we build on what's available? And so we wanted to address those provider concerns, the client concerns, making sure we had process and workflow in place. And a lot of the concerns from the providers really were around safety. What happens if a client escalates? What happens if they report some type of acute situation or crisis while they're being seen remotely? The providers also had concerns, particularly the psychiatric providers, around how do we assess our client correctly? They were so used and so tied to the traditional way of looking at a client visually, that even with telehealth, there was concerns about how do we get the client to look in the right place? How do we get them to take steps? How do we motivate them or engage them remotely? And then from the client perspective, it was early on, it was a bit disconcerting, especially for those clients that have fears or have concerns about technology and screens and cameras and microphones. And so we wanted to make sure that we found the best way to do that, as well as to give our clients the opportunity to experience it, but not require them to do it. And then we built process and workflow around it. And I thought I had all the answers and that we would have early adoption and fast adoption. And 18 months later, we had not much had changed. We had a few providers that were actively using telehealth, either because they were working remotely full time or because they themselves used it in their private practices and were quite comfortable with it. The next things that we had to look at was system acceptance. We found that we were constrained by some of the guidelines as far as implementing BAAs, making sure that the platforms being used were HIPAA compliant, making sure that our clients could access the proper formats. And then we also had social constraints that we were concerned about. The idea that when we move to telehealth is it changes the social interaction. This was particularly important, I think, for some of our clients, whether they were in our IDD department or our clients that were used to the sound clubhouse day room programs, where they could come and have social interactions in a way that had helped them have human contact. And I think we've done a good job of moving groups and some of the social interaction to a virtual format, but I don't know that we've completely closed the circle on how do we actually help people to feel connected when they are socially separate in that way. And so that's something we continue to work on. Next slide, please. So when I mentioned rapid expansion, the pandemic, when it arrived in March, really changed the way that we adopted and looked at telehealth. In February, we had 26 telehealth services, and at the beginning of September, we had 7,000 services. So while the pandemic has changed the way we do business, it has certainly opened up our providers and I think our communities to the idea that telehealth is a very much mainstream, reasonable way to provide services. And so we looked at multiple platforms. We've actually been able to repurpose our original hardware-based services to address on-site services so that we're actually able to socially distance our clients that do want to be seen in person or need to be seen in person because of their inability to either access the platforms, their desire to be seen in person, or because of other social determinant of health issues. It's also opened up lots of technology opportunities. We're exploring how do we do more with better understanding our clients from distance. And so we're currently looking into some biofeedback devices that we may be able to provide to clients that help us better understand what's happening to them in the community. We're looking into different ways that we can communicate and interact, as well as put things together that are meaningful for them. And so we, when we talk about the social determinants of health and telehealth, what we have found is access, opportunity, and ability have been things that have either really benefited clients with previous social determinant of health issues or has widened the gap. And so some of the key things that we've been able to improve for clients with telehealth is around transportation. Some of our clients would have to travel an hour, hour and a half each way by bus or by multiple forms of transportation for a 30 to 50 minute appointment. and then they would return the same trip. There's also cost associated with those trips. And so we found that by being able to offer telehealth services, it did put a few dollars back in our clients' pockets. It gave them more funds to direct towards the things that they had value for. We also found that for people with children and childcare issues, telehealth really minimized the impact and the cost associated with those things. And conversely, also has dramatically cut down some of our no-shows or last-minute cancellations when transportation or childcare fell through and clients weren't able to attend an appointment in person. Now, all of a sudden, with telehealth, they're able to still receive that service. They're able to still access the care that they need, which is really important. And then ability, and this is, I think, one of those challenges that not only our clients face, but our clinical staff and our psychiatric staff face. It's the ability to use the telehealth platforms and access services. Just the technology piece is always a challenge. And so we have done a lot of internal training around the appropriate ways to provide telehealth, maintaining professional standards, making sure that we're accessing, or not accessing, but we are planning for crisis response for clients, making sure that they understand what to expect in a telehealth session. But also we've created some guidelines and documentation for our clients that we can provide to them to help educate and coach them through accessing the different systems that we use. We've made several of them available based on client preference or client ability to access certain things. And so it has created a lot of new opportunity for clients to receive services in a way that is more catered to them, as opposed to being prescribed to them by the system. And I think we've had a lot of good feedback on that, but we've also found that there is a percentage of the population that has kind of been left behind. And so we actively work to make sure that we address that. And so we've made phones available to clients on site, as well as mobile phones that they can access services. We've put some tablets into clients. We put tablets into clients' hands in the community so that they can hopefully access those services better. What we also found was many of our clients that do have Wi-Fi enabled devices relied on public locations to access Wi-Fi, which tend to no longer be available to them, or they're not able to spend time there like they used to, whether it was a Starbucks or the library or some other building that offered free Wi-Fi. And so we've allowed Wi-Fi and expanded our Wi-Fi network so that clients that need to access services can sit in a car in the parking lot and get on our network and do that. We have the tablets and telehealth units available so that if they need to come in, they can access a provider that's in the community. And so really working to try to make sure that we can meet the need as it arises. Next slide, please. And so our IDD department has been really kind of spearheading some of these efforts. Early on in the beginning of 2020, they had been working with this Tacoma DDA to put a telehealth unit in that location so that we could expand the IDD services. That team was located in our Auburn office. And now they were able to meet with clients at the DDA office in Tacoma virtually. They were able to coordinate and provide direct service with the DDA representative. And so things were able to be answered quicker. There was more collaboration, and it was an easier way for people to access services rather than having to travel from Tacoma to King County, or sending clinical staff from King County to Tacoma, which meant there's actually more time available to deliver services, or more time to make available to clients in need of services. We also looked at providing telehealth devices to some ERs early on in the pandemic, when clients would show up at the ER and clinicians weren't going in. We wanted to make sure that they were still able to get a connection with us. We wanted to make sure that they were getting a good evaluation so that there was reduction in unnecessary hospitalization and a reduction in unnecessary time spent in the ER. And that went okay. We did run into some technology challenges with that around who's going to maintain the devices, how are they going to get on the internet, and whose system are they going to use. And then we've also run into some challenges around IT rules and regulations in protecting networks. And so unfortunately right now our pilot with devices in the ERs has come to an end. Only because we weren't able to consistently be able to provide that service. But we do hope to one day be able to provide that remote connection to an ER. We've found that rather than having a client wait for a staff person to arrive, if we can make that connection sooner, it's certainly possible that a client will need to wait in an ER for a much shorter period of time. There's a higher likelihood that they may be able to be de-escalated faster and avoid any unnecessary responses, as well as the opportunity to quickly move them along so that the ER staff can move on to other important issues rather than maintaining and monitoring somebody while they wait for that outreach response. We've had great success with placing telehealth devices in the group homes. We've dramatically increased staff involvement, whether it's the medical staff or the day staff, in getting them connected to the providers, making sure that everybody is working together. It's also allowed some direct intervention and intervention coaching from the clinical provider to the staff and with the client so that everybody's on the same page. So the increased collaboration that's brought has been fantastic. And then caregivers and guardians. Telehealth has been just a huge benefit in making sure that the caregivers and guardians can be involved in the access or be involved in care when they want to be, and without necessarily having to take significant time away from their other responsibilities. It has created the opportunity for our caregivers and guardians to be able to telehealth in, join a virtual session. We've even been able to figure out ways to have them join a face-to-face session or in-person session so that they are more involved, and then can also direct questions to our medical providers or psychiatric providers and just have a better understanding and care, as well as raising those issues that they have or the concerns that they have at a time where they can get active feedback, which has been fantastic. Next slide, please. So groups, this has been a bigger opportunity for us. Rather than running in-person groups at each location, we've moved them virtually, which also allows and has expanded clients' abilities to access groups no matter what site they were traditionally being seen at. And so now we can offer a group calendar that's not based on location, but is based on client interest, based on things that they would like to be involved in. And so we've been able to grow participation as well as expand potential offerings, which has been really positive for clients that would like that opportunity for social engagement and really respond well to that group atmosphere. We are working and planning for the future, which means how do we help maintain that virtual opportunity while also having an in-person group. And so that's the next step, is figuring out how do we bifurcate or offer the opportunity to attend a group, whether it's in person or virtual. We have had some interesting service issues related to groups, particularly around our substance use delivery. We've had to be more mindful of the drain and kind of the malaise that can set in from being in extended telehealth sessions or Zoom meetings. The idea that our traditional IOP groups would run for 3 hours at a time, trying to move that into the virtual realm has not gone well. It's been very difficult for clients to participate and engage. It's been difficult for the providers to participate and engage. And so we have started breaking those down and trying to maintain and follow the state guidelines while also putting together a presentation that is engaging and respectful of the clients and the providers. We've noticed a shift in service dynamics, how we provide services, and even just overcoming some of the barriers from our own providers around having video on and providing that visual and kind of moving from there. We've also had some service dynamic issues just in the way that technology sometimes works and sometimes doesn't work and how we have to roll with it. And so making sure that, you know, if technology is working with us, if it's not working with us, we have a plan in place and are adjusting so that the client gets the service and that we can maintain that. Some of the system impact overall that's been really, I think, a great opportunity has been the reduction in travel. Whether it's a client traveling for extended periods of time, the costs associated with that, or when we send our clinicians out into the field or out to homes, all that travel time reduced our ability to offer services or offer additional sessions to clients. It also reduced clients' available time during the day. And so we've been able to give some of that back, which also means that we have more opportunity to serve people. Our staff have been generally really receptive of this. They have embraced it. They are becoming proponents of offering this service, and many of them are hoping that we'll be able to continue this post-pandemic, as are our clients. And then collaboration, that's been a big thing that's been hugely beneficial in being able to have those other providers in the room, whether it's medical staff or a care provider, being able to put everybody together at a time that is just instant on. Everybody can just make it there. You don't have to plan for travel, you don't have to plan for lost opportunities. So that's been very helpful. And I think that's it. Thank you.
Great, thanks, Ethan. And we do have some time for questions, and we do have a couple questions. So for Ethan and Wayne, and maybe, you know, Chris, if you can have information. So there's two questions. Well, the first one is really about engagement with telehealth. So how have you addressed it where patients don't want to engage in telehealth anymore and you don't really have staff to do direct outreach? Have you, do you have any strategies for maintaining engagement?
For clients that aren't interested in doing telehealth, if we can engage them on the phone or another format, then that's what we'll do. As far as outreach goes, we are still outreaching. Some of the outreach has been reduced, but it's not been stopped, other than in places that the facility itself that we would be outreaching to has requirements in place that prevent outreach. So some of the adult family homes, the nursing facilities, from time to time the ERs during the pandemic. And so I think the biggest thing we try to do is strategize around how, if a client does not want to engage in telehealth, what ways will they engage with us? Will they come into the office? Can we go to there? Can we go to another third location where we're not going into a closed facility? Are there other options? And so really just trying to figure out what.
I would echo things that Ethan had said. The only addition I would make for us is we do have 2 community health workers on our team that are able to participate more into the community, go see patients, kind of help with motivation, just whatever they need, even transportation, motivation, if they're suffering with depression and isolation and those kinds of things. They've been really instrumental in helping with our patient caseload.
Great. And then there's another question about what does the shift look like moving away from telehealth services while maintaining the state guidelines? And that question was from Michelle. So I think maybe that's referencing Ethan, your pre-COVID attempts.
Part of our shift, we do want to bring back face-to-face, but we know that that's not always the best way to do things. And I think as we see more of this in the future, telehealth is going to be around to stay. I personally, encourage advocacy at the state level, the community level, around helping to maintain telehealth, especially for behavioral health providers. Because sometimes they do fall into a gray area within the HCA and some of the state and federal guidelines. That said, we are actively working to figure out how do we maintain telehealth in a way that does meet guidelines. And so we're planning for what that would look like if we go back to pre-COVID. We are planning on what that would look like if it's a change. And so we're working to be very fluid. And that's why I think we've spent a lot of time testing out different systems, working with hardware versus software versus the next big thing to come along, so that we'll be prepared for it.
Great. There's another question about how has your suicidal interventions changed, or has it during COVID? So maybe that's, especially with telehealth. And Wayne, do you want to?
Sure. So I think for us, for those who will engage with video chat, not much has changed. We do screen sharing, to review our safety plans. We certainly, as a practice, we just we assess PHQ and GAD on every visit, and that includes telehealth visits, whether it's video or phone. So I guess, one of the downsides of phone would be, you just don't get some of those facial cues, or even some of, more of the body language that kind of can go along with a slip into darker thoughts. But certainly here, we're just, I guess, fortunate to know our patients fairly well. It's a small community, and some of our folks have been coming to us for a couple of years now. And so I think we've had a really good sense on the pulse. The one thing, I guess, that has had an uptick here in our county has been per capita, an increase in suicide attempts of children in the school. And so we are involved at the school as well in providing care, at least to those 13 and up. So I would say, to answer that question succinctly now at the end, would be, I don't think there's been much of a change for us, but that might be quite often because of our rural and very small community here.
Great. And Ethan, do you have any comments?
So I would echo what Wayne said. Our school age population, I think, is one of the biggest concerns for us right now. They don't have that safe space where they used to be able to leave the house and go to school and have that opportunity. And so our child and family clinicians do spend a lot of additional time trying to do safety checks, making sure that they are just checking in more frequently with the client, but as well as making sure the client has a safety plan, a safety place they can go, and just trying to help them feel that there are additional connection opportunities out there for them. With our adult population, I don't know that we've seen much difference. We do, by standard, try to assess a client's location at the start of every call, remind them, if something concerning happens, what that response will be and how we'll do that. So we do want to make sure that they know that we are here to support them and how we'll do that and verify where they are. Outside of that, I think we just see a lot more short check-ins, a lot more visits, and then we are doing more home outreach, I think, than we did previously, just for those higher risk clients, for those ones that need that visual check-in that we may not get over the phone.
I'd like to add one more thing, Stephanie, if I could.
Yeah,
Go ahead. It occurred to me with when Ethan was talking, the one other thing that's helpful with our adolescents, especially at the school, we are there every Monday. And our schools here, they are in for half days, Monday through Friday. We have instituted the last few weeks walk and talks. So we're safer, we're still both masked, and I walk about a mile with each kid and do the session during that time. And we've had an uptick, it seems like, of mood and decreasing isolation like that, because otherwise they're going back home by 12:30 in the afternoon, and there's not a lot to do in Dayton. And so this has been helpful, at least for those kids who will engage with us. So I would encourage folks with adolescents, if you're able to, do some walk and talks. Yeah.
That's great. And obviously the dynamics, there's been a lot of stress on providers around COVID, just adapting to the changes. And in no way is telehealth, going to solve all this, but there's definitely opportunities and ways that can be, plugged into your practices and how you adapt to delivering integrated care. So one resource that I wanted to highlight for next slide is the Behavioral Health Institute has been developing telehealth, a 201 series and a 101 series to work through a lot of these new changes of how to deliver behavioral health services over telehealth. So there is a flyer handout attached to the GoToWebinar that you can download for the registration, but wanted to highlight this as another resource to keep in mind in terms of developing out telehealth. So thanks again to the panelists and for sharing your experiences and information around telehealth.